Good morning. Thank you to Professor Chowie and to the organizers of the conference for this kind invitation to speak. My name is Dr. Jahan Karim. I am a clinician and academic researcher at the University of Oxford, and it's my great pleasure to be here today to speak to you about the first trimester anomaly scan and what it will take to make this a standard of care. So just to begin with a little background information, as many of you will know, in many countries across the globe, most women are offered at least 2 routine ultrasound scans in pregnancy, the first usually taking place between 11 to 14 weeks. And here the aims are to confirm fetal viability, establish gestational age using a crown rump length measurement, identify multiple pregnancies, and measure fetal nuchal translucency as part of a combined screening test for Down syndrome. In the second trimester, the scan usually takes place between 18 and 21 weeks. And here again, the aim is to confirm fetal viability, also take fetal measurements. But the main focus of this scan tends to be around the visualization of fetal anatomy and the detection of fetal abnormalities. And what we're really going to be discussing today is the potential for a shift in practice, where we begin to think about the detection of fetal abnormalities in the first trimester as well. So to start off with, why challenge this existing model? Well, as many of you will know, the majority of organogenesis is completed by 10 weeks gestational age. And many chromosomally abnormal fetuses will have structural malformations. And so in essence, undertaking a first trimester anomaly scan is in fact complementary to the current aneuploidy screening approach, whether that be with the combined screening test or cell-free DNA testing. Third, the sociopolitical context in recent years has changed quite a bit. In the United States, the Supreme Court abolished the legal precedent set by Roe versus Wade, thereby reducing the reproductive rights available to many American women. And while that was an American decision, it's clear that the reverberations of this decision have been felt across the globe, with renewed discussions about gestational age restrictions for termination of pregnancy taking place in many countries, including in the UK. And so a renewed conversation around what anomalies might be detectable at an earlier stage in pregnancy seems increasingly relevant. Finally, there have been a number of technological advances in image acquisition, which now allow for the visualization of fetal anatomy and also the detection of structural abnormalities within the first trimester. And in a recent systematic review published by our group, we showed that approximately 50% of all antenatally detectable fetal abnormalities can be diagnosed within the first trimester of pregnancy. And just to give you a sense of just how much that technology has changed, if we look here on the left, you can see a research scan taken in 1975 and published in BJOG at 14 weeks gestational age. And on the right-hand side, a much more typical first trimester image that we would see every day on our screens in 2023. And you can really appreciate the difference in terms of resolution and what you might be able to identify over that 50-year period and how that has changed. And certainly if we look at even that standard mid-sagittal view image that we tend to get in the first trimester in order to measure a CRL or to measure nuchal translucency, you can see there are a number of structures just highlighted on the screen here that you could begin to think about evaluating even in the most basic of anomaly scans. And so today we're going to address a number of questions. The first is going to be, what is the evidence supporting an assessment of fetal anatomy in the first trimester? Second, how can we use our knowledge about systems factors to optimize screening? Third, I'm going to talk a little bit about the status quo for screening in England. And while I know that this is an international congress, I think that there are a number of lessons that we can learn and can be applied more generically from this data. Finally, what do parents want? Do we have any idea of how to design a system around parental needs in the first trimester? And finally, we'll finish with some concluding remarks and hopefully some points for further discussion. So just to begin, I'm going to talk you through a fairly large systematic review and meta-analysis that was conducted by our group in 2017, looking at the sensitivity of first trimester ultrasound for the detection of fetal abnormalities. And in this study, we looked at 3 separate groups. In the first, we evaluated major abnormalities in a low risk or unselected population and found a sensitivity of approximately 46%. We then looked at the evaluation of all types of abnormalities, and this included minor abnormalities, in a low risk or unselected population. And here, as you might expect, the sensitivity was a little bit lower at 32%. We then looked at the evaluation of all types of anomalies in a high-risk population, and here the sensitivity was much higher at 66%. Now we know that the sensitivity of a test should not be impacted by the prevalence of the disease in the population. So why are we seeing sensitivities of 66%, so almost double in the high-risk group than we might see in the low-risk group? And we believe the reason for this is because of targeted screening. So women who are at high risk of fetal anomalies are much more likely to be evaluated in a tertiary care center by an experienced sonographer using the most advanced equipment available in the department and taking a sufficient period of time to adequately evaluate all of the anatomy in question. And so the good news here is that if sensitivities of 66% are achievable in a high-risk population, then there's no reason why such sensitivities could not be achievable in all types of populations on a routine basis. And that really is the question. How do we optimize first trimester ultrasound 7 sensitivity for the detection of fetal abnormalities in low-risk and unselected populations? And our group believes that the way we can do this is by focusing on screening test factors. What the evidence tells us is that if we optimize the gestational age window for screening, use an anatomical protocol with a structured approach, focus on sonographer training and experience, use the correct ultrasound equipment, and have clear and auditable image standards, that we might be able to optimize the screening sensitivity of the first trimester test we provide to our patients. And while a full discussion of all of these factors is outside the scope of this talk, there is one specific factor that I would like to hone in on just a little bit, and that is the use of an anatomical protocol. So the first question we always ask ourselves in our group is, does a structured approach matter? And the answer is yes, it does. Now, these are the results from that same systematic review and meta-analysis that I presented earlier. And one of the key findings was a statistically significant association between the use of an anatomical protocol and sensitivity of screening. And this was shown in all three groups, as you can see in the graph here, in the detection of major anomalies in low risk and unselected populations, in the detection of all types of abnormalities in low risk and unselected population, and also in the sensitivity for high risk populations as well. And what we've been able to show is not only is this true for looking at all types of abnormalities, but it's especially true and perhaps more significant for groups of anomalies that are traditionally thought of as being difficult to detect in the first trimester. And one key example of this is major cardiac abnormalities. And so I'm going to share with you the results of a large systematic review and meta-analysis which focused on the detection of major cardiac anomalies in the first trimester. And this was in low risk and unselected women, included 43 studies representing approximately 300,000 fetuses. And what we were able to show was that the sensitivity for first trimester detection of major cardiac anomalies was approximately 50%, but the type of protocol you used made a significant difference to the results. So when we looked at the studies that used no formal protocol, there is approximately 35,000 fetuses involved in those studies, the sensitivity for major cardiac anomaly detection was 13%. When we looked at those studies that used a 4-chamber view without Doppler as part of their routine protocol, that sensitivity increased to 33%. When we focused on studies looking at the 4-chamber view with color flow Doppler, that increased to 39%. When we looked at studies looking at 4-chamber view and the addition of outflow tract views, but with no Doppler, that sensitivity jumped to 58%. And when we looked at studies which used the 4-chamber view, an outflow tract view, and Doppler, we found that that sensitivity increased even further to 78%. So in essence, when we look at the sensitivities and how they change with the protocols that are being used, we can see that the sensitivity improves in a stepwise approach with the addition of color flow Doppler and outflow tract views. And so when we ask ourselves, is it important to have a structured approach? The answer is yes, having an anatomical protocol and a structured approach is probably the most important factor in the detection of first trimester abnormalities. And when we think about major cardiac anomalies or cardiac screening in general, certainly use of color flow Doppler and outflow tract views can be used to optimize detection rates. So the next question I wanted to address is, what are we doing now? So I'm going to share with you some data that we have analyzed from the English context. And the reason we started to look for it is because we felt that any discussion which was looking to modify an existing screening practice would require an understanding of the status quo. And I think there's actually quite a lot that can be learned by looking at this data, even on an international scale. So I'm going to share with you the results of a nationwide study of current first trimester ultrasound practice in England. And really the main aims of this study were to determine how first trimester ultrasound is conducted across the country. We wanted to know, are current national recommendations being followed? What are the local protocols and policies? Are the National Health Service trusts in England assessing fetal anatomy in the first trimester, despite the fact that there are no formal recommendations for practice to do so? And to what extent does practice differ from one trust to another? And what we did was we distributed a survey out to every single public health funded, so National Healthcare Trust in the country. We had an 83% response rate, and you can see here that that was quite well distributed across the country. And what we found is that despite an absence of formal recommendations regarding first trimester fetal anatomy screening, that 77% of those who responded to our survey performed some type of routine assessment of fetal anatomy in the first trimester. We found, however, a widespread variation in practice. We saw that 62% of hospitals use a formal anatomical protocol for screening, but that protocol varies widely in terms of what structures are being assessed. So the vast majority of hospitals with a protocol will look at the head, fetal limbs, and cord insertion. We then have about 70% who also look at the bladder and the stomach. We have approximately 15% of hospitals looking at the fetal heart and fetal spine in the first trimester, and then fewer than that, of course, looking at the fetal kidneys, face, neck, and thorax. And what we decided to do was to assess how these protocols differ from one region to another. So if we think back to that map that I showed you, we took each of those regions and we gave them a letter ranging from A to I, so that they could be completely anonymous. And what you can see in this graph in front of you is that we've listed what percentage of trusts or hospitals are offering a first trimester anatomy assessment in each of those regions. And as you can see, in regions A and B, all of the trusts are offering an early anatomy assessment to their patient, and the vast majority of those that do so in a structured way using a protocol. However, when we move towards regions H and I, we can see that much fewer than half of the responding hospitals offer an early anatomy assessment, and of those, only a quarter use a structured approach. So what does that mean? That means that if you are a woman living in region A in England, you are much more likely to be offered a first trimester anatomy scan, and that scan is much more likely to be done in a standardized and structured way. And in fact, although I haven't shown the data here, that scan is actually much more likely to be detailed in terms of the anatomy that the protocols look at. And so that suggests that there's a significant difference in practice based on region within England. And so overall, we found a huge variation in care across the country. And that is because there's no national standardized protocol, there's no national standardized training, and there are no national recommendations. And what we also found is that the consent process being offered to patients in terms of how well informed they are of what is happening with their first trimester scan and whether or not anatomy evaluation is being included is actually quite inconsistent between hospitals as well. And as a result, women have haphazard screening, depending very much on where they live and on what hospital they present to. And that results in inequity of care and, of course, medical legal concerns. But once we found the results of that study, we thought, does it matter? Does it matter on a population level? whether there's a huge variation between how one hospital conducts a first trimester scan compared to another one in a different part of the country. And in order to answer that question, we decided to conduct another study. And we asked ourselves the question, do hospitals in England using a protocol-based approach have higher detections rates in early pregnancy than those who do not? And in order to do that, we did a UK-based analysis of all the hospitals that participated in our survey of practice using what we call NCARDS, which is a National Congenital Anomaly Disease Registry. And we looked at approximately 1 million pregnancies that were screened between 2017 and 2019. And what we found was actually quite interesting. We were able to divide anomalies into one of three groups. In the first group, we saw a group of anomalies which were minimally affected by the use of a screening protocol in the first trimester. And you can see those here. So if we look at acrania, exomphalus, and gastroschisis, in blue, you can see the detection rates prior to 16 weeks in those hospitals that had no screening protocol whatsoever. And in green, you can see the detection rates prior to 16 weeks in those hospitals that do have a screening protocol in place. And you can see really there's very little difference in the detection rates between the two groups. And our feeling is that it's because even if you don't have a screening protocol in place for first trimester anomalies, if you're taking a crown rump length measurement or you're measuring nuchal translucency, you're highly likely to recognize an acrania in that setting, even without a formal protocol in place. However, when we looked at another group of anomalies, and those are listed here, these are anomalies where you can see in blue the detection rates prior to 16 weeks in those hospitals without a formal screening protocol, and you can see how they jump, how they increase when you introduce a screening protocol. So when we think about encephalocele, the detection rates go from 25% to 68%. For facial clefts, from 3%, we know that facial clefts are typically very difficult to diagnose in the first trimester, but if you have a protocol, that sensitivity increases to 18%. For spina bifida, from 12% to 30%. For limb reduction defects, from 8% to 44%. And this is national population level data in England. And again, for cardiac defects, as you can see at the bottom of the screen, as we showed earlier, the impact and the significant impact of using a protocol. Finally, we were able to identify a group of abnormalities where the detection rates prior to 16 weeks were very low, regardless of whether you use a protocol or not. And these were congenital diaphragmatic hernia, bilateral renal agenesis, and lethal skeletal dysplasias. And what this tells us really is that these are anomalies which probably would be better a focus of the second trimester scan, or at least a later scan, than from routine screening in the first trimester. So I hope that gives you some insight into the type of anomalies that might be amenable to screening in the first trimester and how the detection rates are actually quite different depending on which anomaly you're discussing. And so when we think about current first trimester screening for anomalies, we can see that despite an absence of formal national recommendations, first trimester screening is taking place across England because there's a general interest in doing so. The approach, therefore, is ad hoc. It's lacking in consistency and standardization across the country. Nevertheless, it is having a real-time impact on the diagnosis of fetal congenital abnormalities within our country. And while there is no unified policy, we can see that a lot of variation in practice is emerging, and it's dependent on individual hospitals, but actually also dependent on individual sonographers. And this variation is linked with different detection rates at a population level. So yes, when we ask the question, does it matter? Yes, it does. Moving along to my next slide. Finally, I'd like to talk about what parents think of first trimester anomaly screening. And in order to do that, our group conducted a study known as the ACAS study, and this stands for the Acceptability of the Early Anatomy Scan. And this was a national multi-center prospective study, the objectives of which were to explore parental attitudes towards fetal anatomy screening in the first trimester. And we had two distinct cohorts. In cohort A, we had parents who are currently pregnant and presenting for routine low-risk obstetric ultrasound screening within the national publicly funded healthcare service. In cohort B, we had parents with a previous screen-positive pregnancy or child affected with a congenital anomaly answer the survey as well. When we looked at cohort A, parents were recruited from one of 10 sites across England and Wales, as you can see here. For cohort B, recruitment and consent was facilitated online via two large national UK-based charities known as Antenatal Results and Choices and Shine. Prior to undertaking the study, we gave patients a list of potential benefits and risks of a first trimester anomaly scan. In terms of benefits, we described extra time for testing and speaking to specialists to make preparations for the baby's birth, and if they wish to think about termination of pregnancy. And for those deciding to have a termination pregnancy, that having this done earlier might be safer for them to do so. In terms of disadvantages that we described, we told them that early scanning might suggest that the baby has a condition which a further test shows is not to be the case, and this might cause worry and further unnecessary tests. In terms of the results, in cohort A, we found that 91% of parents would consent to an 11 to 14-week scan in a future pregnancy, and we asked them for the reasons for accepting that scan. These included a desire for early reassurance, early information about the baby, time to prepare for the birth of an affected child, earlier access to genetic testing and termination of pregnancy if required. We had approximately 3% of the group who would decline a first trimester scan in a future pregnancy, and the reason for this was increased anxiety in the case of an inconclusive result. Now, when we looked at the results from cohort B, these were analysed separately, but actually the results were remarkably similar. We found that 95% would consent to a future first trimester scan, and the reasons for accepting that scan were very similar, as were the reasons for declining. In terms of what parents thought, they gave us a number of written essays with quite a lot of detail in terms of what they thought about a first trimester anomaly scan, and I'll share some of those insights with you here. From cohort A, we had one parent say, "The earlier the better, and the more information the better." Another parent said, "The longer an anomaly is left to be discovered, the more you imagine a life with that child. Despite the margin of error, I would take up this opportunity to make informed decisions as soon as possible." From cohort B, as you might expect, we had a much more kind of nuanced series of responses from parents who actually have had the experience of a child with a fetal anomaly. Here we have a parent, a father actually, who said, "In the case of a positive result, you need time to consider the information quietly with people you trust, so you feel that you have covered all the bases before making a decision and you don't feel rushed." Another woman said, "I strongly feel any early information or diagnosis is essential and important, particularly for those of us who have a family history. Any earlier testing could potentially reduce my anxiety to 11 to 14 weeks. This would be huge for us." And so in terms of what parents want, we've shown that most parents would consent to an early anatomy scan at 11 to 14 weeks, in addition to the current standard of care of anomaly screening in the second trimester. Both low-risk and high-risk parents feel that this additional test would be beneficial. Some parents, including those who did not want screening for Down syndrome in first trimester, would still opt for first trimester anatomy screening, and we saw that it was also seen as a desirable addition to care, even in those parents in pregnancies where a termination of pregnancy would not be considered, even in the setting of a severe or lethal abnormality. And so, a few take-home messages. I know this has been a whistle-stop tour through the first trimester anomaly scan. We've discussed a number of different aspects. Unfortunately, we weren't able to cover cost effectiveness and some of the logistical aspects, which are very important, but if you have a burning desire to ask a question, I'm of course very happy to answer that. What we've seen is that a structured approach to the first trimester scan is extremely important. There are important variations in screening, and when these occur, these lead to variations in outcomes. We weren't also able to talk, we talked a little bit about expected detection rates, and we can see that these are known. And I can also tell you that the false positive rates are relatively low. And again, we can discuss that further if any of you want to do so. In terms of parental attitudes, we see that parents support being given the choice and information from a first trimester anomaly scan. In terms of cost effectiveness, although we didn't cover it here, our group has shown that it would be cost effective in the setting of the English healthcare system. And finally, it is, of course, feasible and is currently being undertaken by a number of centers internationally. So, thank you very much for listening. I would like to acknowledge a number of individuals and healthcare centers and charities that have supported our work, and I look forward to our discussion and any questions you may have. Thank you.
Great presentation. It's actually a bit frustrating to hear that in a country which is the base, the home for Professor Nicolaides and the headquarter for ISOG, you don't have national protocol for first trimester screening. I hope it's under development.
Yes, I'm sorry to be disappointing to you. It is, as always, always a bit frustrating for those of us who sit on the kind of cutting edge and forward area of thinking. But in England, it's like a big ship. Once it moves, the whole ship moves and everything comes with it. But it does take time to move. And like with all change, it needs to be acceptable to lots of different people, not just doctors, also public health physicians, people who believe, who have a lot of problems with screening, who want to understand what the impact might be on a more global scale, also to the sonographers who are doing the scan, and of course to parents. So lots of stakeholders. And I think, yes, it has been slow, but I am hopeful that we will get everybody on board and we will do it in a way that is acceptable to all of the stakeholders, and done in a way that we actually design a system that meets the need and meets the desires of the parents who are going to be accessing the system. And this always takes time and a lot of discussion and negotiation. And I think we shouldn't be scared of that. I think it's important that we do that before we set anything in stone. And as we know, fetal anomaly screening is very cultural. And so what decisions are made in England and what feels right for an English population may well be different in the Ukraine, in Germany, in the United States. And I think we need to be very cognizant that we are designing systems that meet the needs of our population group, that are fair and balanced. And I think that always takes time.
Yeah. And I think we need to take into account that although for us, it's clear it's first trimester screening, we push everyone and the whole system in terms of first trimester screening. There are other people who think differently and who have a different opinion about first trimester screening, about the very early detection of major problems, or actually problems that don't lead into termination of pregnancy. They discuss about the anxiety that causes these kind of early detections where you don't really have, another alternative. Well, you could discuss further genetic testing with them. You could discuss that maybe termination of pregnancy is an appropriate way to go for. But what about defects where you say, well, we'll need to deal with it after delivery, like a simple cleft lip and palate, well, which certainly can be resolved after delivery without too much problems. Obviously, the early detection causes more problems, causes more anxiety. And as much as I'm in favor of first trimester screening and first trimester detection of all kind of major defects, I need to agree that there is a certain point of anxiety that can be caused by the early detection.
In order to continue the discussion with Professor Billard, Professor Kagan, can you imagine that one day you wake up and the German government has banned first trimester screening, said we don't pay for it?
Well, to be very honest, our system is much more unlogic and much more complicated. I don't want to go too much into details. It's boring for the population, but for our audience. But we don't have first semester screening, combined first semester screening implemented in our system. It does have historical reasons that there is a certain reason why we don't want to have screening for trisomy 21. Okay, that's one side of the story. So if you look for the official screening policy in Germany, you won't believe it, it's still done on maternal age. But on the other side, we've introduced self-DNA screening in a way that, again, it's difficult, but it does have some legal aspects. You can do it if you see that there is an increased risk in pregnancy. Okay. Now, the government has not clearly defined how this increased risk looks like. So at the end of the day, if you feel as if you have an increased risk, even though it's not objective, it's just a feeling, you still have the possibility to do this test. Okay. So at the end of the day, what we see now is that many people many women ask for self-fetal DNA screening. And even the younger population, although there is no real reason for doing it, just because the government gave it free, but actually they highlighted that it should have been done, or that it should be done in a high-risk population. So that's why I said it's difficult. We need to sort this out with guidelines. That's our task. Okay, that's what we work on, because we didn't get the help from the government, obviously due to legal reasons. But anyway, that's how it is.
Okay.
I think just one comment, it's important just to recognize that cell-free DNA testing has really changed the landscape in the last 5 or 10 years, as we well know. But because the gestational age at which you would consider cell-free DNA testing is around the same time as you might do first trimester anomaly scanning, I think there has been a considerable rethink, I think, in every country across the globe as to what is now necessary. There's been obviously a lot of excitement around cell-free DNA, and I think the initial gestalt was maybe this means it's the end of the nuchal translucency era, perhaps it's the end of the first trimester anomaly era. This is maybe something that will cure everything and solve every problem that we've ever considered. And I think as we are learning more about cell-free DNA testing, we are perhaps examining how we could have a synergistic relationship between ultrasound and cell-free DNA. And I think as we learn more and as we are getting kind of more familiar with this dynamic and this relationship, we are also learning what the optimal combination would be. We are also still discussing, I think, internationally, timing. Should you be doing first trimester scan before cell-free DNA testing? If you can have a DNA test at 9 weeks, should that be the first thing that you do? And I think that discussion is still ongoing, and perhaps even quite a personal choice for each woman. So I think we need to recognize that perhaps has also slowed things down or changed the conversation.
So we thought that an IPT will be the answer to our problems, and it gave much more problems and much more questions.
Well, one could, if you discuss it from a purely financial point of view, okay, I'm certainly not in favor of this, but one could argue that you do a very, very quick first trimester ultrasound examination just for dating, these basic things that take 5 minutes. Then you do a cfDNA test, and you do the detailed anomaly scan at 20 weeks, because I agree that there are less false positives with the second trimester scan than with the first trimester scan. Okay, and then you'll identify all the details but anyway, okay, all doesn't mean all, because the overall detection rate of fetal defects throughout the whole course of the pregnancy was just about 40% in the EuroCat registry, 40%, compared to about 50% plus minus with a detailed ultrasound examination the first trimester, obviously in more expert hands, okay, that need to be taken into account. But if I just think it through by a financial point of view, one could argue, well, why should we bother with a first trimester ultrasound examination? Just rely on a cfDNA test and a second trimester test, okay? If the baby has trisomy 18, it dies anyway. If it got anencephaly, it dies anyway. So it doesn't make too much difference. But I think this is the wrong way to go through and the wrong way of thinking. We've done plenty of studies highlighting why it's so much important to do a first trimester scan. And in our recent study, we looked to the risk of termination of pregnancy in the first trimester and the second trimester. And while we've done a first trimester DNA mostly of dilatation and evacuation with a 5% risk of complications, we had a 25% risk of complication with induction in the second and third trimester. I was very much surprised about this high risk of complications. But when I went through the literature, the others had the same problem. It's about 20-25% because you induce to a time where you don't do an induction, and that has more problems than just putting in a pill into the vagina. So from that point of view, it's an issue of maternal safety to do a detailed ultrasound examination and to sort out the main problems where the patient decides for termination of pregnancy.
Dear Professor Kagan, do you think that for some pathologies in certain diagnostic settings, the cell-free DNA can change its position from a screening test to a diagnostic test?
That is interesting. To be honest, now let's talk about it from a statistical point of view. If the baby looks like trisomy 18 with increased nuchal and many defects, and the cfDNA test is abnormal, what on earth should it have other than trisomy 18? Okay, I could say the positive predictive value is 99.9%. So from that point of view, I think in these particular cases, I wonder whether an invasive test is really necessary. You could do a termination of pregnancy in any case just because of the major defects, and one could consider doing a karyotype with the on the specimen afterwards, just to exclude a balanced translocation, or you could do a test in the mother. That would be okay for me. But I'm a bit afraid that we open a box of Pandora in these situations, okay? That we'll start with these cases and then we'll discuss the same with trisomy 21, where it's much more doubtful whether a positive cfDNA test is really associated with an affected fetus. And we're just doing a retrospective study now. We're writing it down now with about 150 abnormal cfDNA tests with trisomy 18, 13, and 21. And just to give you some rough numbers, for the trisomy 18 and 13s, where the cfDNA test was abnormal for trisomy 18 and 13, and the ultrasound examination was normal, there was a 95% chance that the baby was normal. Okay. And there were few cases where there was still trisomy. That's why I'm still absolutely convinced that we need to do an invasive test in this situation. But in these are the more dramatic ones, where you really should go for an amniocentesis. With the trisomy 21s, we all know that there are babies with Down syndrome that are not that easy to identify by ultrasound. So from that point of view, the positive predictive value was certainly lower after normal ultrasound examination, but again, by far not as low so that you could avoid an invasive test. But certainly not as high that you could do a termination of pregnancy without any further testing. So that's what I mean with opening a box of Pandora. If you give one a small finger, that's what we say in Germany. If you could give one a small finger, they grab the whole hand. And I think this is the dangerous situation. That's why I would actually carry on with the rule: an invasive test. An abnormal CNF test means an invasive test as a diagnostic test.
Thank you very much. Just
to add to that comment, I'm very glad Professor Kagan took the statistical side of the argument, which means that I didn't have to. But if we take the biological side of the argument, just for a minute, because I think it's very dangerous to throw around the word diagnostic test versus screening test. At the end of the day, the cell-free DNA is being produced by the cytotrophoblast of the placenta, and that is being used as a proxy for the fetus. And so biologically, we know, because of placental mosaicism, we know that this can never, and not in all cases, be a true reflection of the genetic makeup of the fetus. And therefore, biologically, this can never be a diagnostic test. And I think that's always something to remember.
Imagine to previous times when we did a CVS, sometimes even for maternal age, we always said there has to be an agreement between the ultrasound examination and the result that you get by karyotyping. Okay, and if you have inconclusive results, even with trisomy 21, you need to be clear with what you do there. Better maybe even consider a retest with an amniocentesis. Don't rely on inconclusive results. Okay, and now with cfDNA testing, it's exactly the same.
Yes. Yes, and so we just need to really be careful about that. I think the strongest critics of cell-free DNA testing and of screening in the first trimester are honing in on this exact point. Is it diagnostic? Is it screening? Do parents know the difference? Do practitioners know the difference? And so I think we have to be very clear that we handle this information and we understand this information, what it means and what it doesn't mean. And I think this is incredibly important for those of us who will be observing our practice, for the skeptics and the critics, even the ones that sit in our own minds.
Yeah.
We need to be really sure that what we're doing is ethically correct.
Thank you very much. This is a great discussion. It can go on for ages and hours. We have one question from the auditory. It is addressed to Professor Villardo, but actually to my teacher, she cannot answer it. Maybe I'll address it to you, Professor Kagan. What about single gene anomaly scan in the Netherlands? Single gene anomaly scan. I'm not sure I understand the question.
Maybe it's whole genome screening. And yes, in fact, in the Trident 2 study, they offered whole genome screening. And from my personal point of view, the lesser, the better. The more concrete you do screening, the better, because you can deal with the results in a better way than if you do whole genome screening, where you get results that you can't interpret, that are partly wrong. The positive predictive value is much lower because the prevalence of these diseases is much lower. So from that point of view, my personal feeling is you focus on the ones that you can deal with, that you've actually counseled the patient before, and then you do the test specifically for the disease and not the other way around.
What about microdeletions? Should we avoid this or should we skip it?
Now, with microdeletion, I think my personal opinion has changed over the years. At the very beginning, I was in favor for an extension, and I see diseases like 1p deletion 1p36, awful diseases. Okay, there's no doubt that an affected fetus, whether the patient opts for termination of pregnancy in these cases. But how often are these problems? Okay, what's the prevalence of these diseases? And it's certainly low. And as such, again, the positive predictive value of an abnormal test result is so low that in a general population, I'm not sure whether this is useful. Again, with microdeletion 22q, it may be possible to do screening, but if you look for the detection rates and false positive rates, they are by far not as good as in screening for Down syndrome. But again, I made 3 women where we identified a fetal defect and a fetal trisomy 21. And by the way, just as a coincidence, we identified the disease in the mother as well. And they had completely normal lives. And here I start to doubt from an ethical point of view whether this is the right way to go for.
Okay, colleagues, do you have any other questions to discuss, or we have?
So there's one question just coming up. whether a CVS is accurate enough in fetuses due to placental mosaics. I think this is quite easy. If there is a fetal defect, carry on with a CVS. That's straightforward. Okay. And if you do have no defect, it depends on why you do an invasive test. Okay. So if you do an invasive test, you do an abnormal combined test. I think I would rather prefer an amniocentesis. Okay. If you do it, well, I don't think anyone does an amnio due to maternal age today, but there I wouldn't care too much, to be honest. Look, there's another question. Do you mean that it's the same one?
The same one, yeah.
By the way, for in cases of major defects in the second trimester, it depends on what kind of examination you want to do. So as we do exomes in many cases today, our geneticists prefer to have CVS samples. So we do a placenta synthesis because it goes quicker, because you can extract the DNA easier in these situations. But that's a technical aspect that should actually accelerate the process from the time of diagnosis, the anomaly, to the end of the genetic analysis.
Okay, this is. Do you have any other questions, Dr. Karim?
No, I think Professor Kagan covered that quite well. I don't have anything to add that's useful. Okay, dear colleagues, thank you very much for this great discussion. I hope the auditory have found some questions, some answers to their questions. And now we will go on with our program further. Thank you very much. Thank you.
Thank you. Have a good day. Bye.